think I'll get started. So for those of you who don't know me, my name is Paari Dominic. I'm one of the electrophysiologists here. So I was deciding on a topic to do for grand rounds, and I was thinking about all the common things that you guys need to learn. Then I thought it might be boring for you guys, so I came up with this topic that is kind of near and dear to my heart, and my research lab is actually based out of this topic, and so I thought I'll cover some of the less known stuff about atrial fibrillation in this grand rounds. And so this might be interesting for more non-cardiologists as well, because I cover a lot of things about inflammation that non-cardiologists could be interested in. So I'm going to talk to you a little bit about atrial fibrillation and kind of introduce you to the topic. And last time when I gave the grand rounds, I didn't realize that there were a lot of medical students here. And kind of what I talked may have gone over their heads because I didn't start off, thinking that there were medical students. So this time I'm actually well prepared for that. Then I'll tell you a little bit about what is the effect of AFib on healthcare and how much it costs, and what is the impact on our healthcare system. We'll talk about atrial fibrillation in conditions that trigger inflammation. So basically, I've kind of separated this talk out into three different components. I'm going to show you evidence that AFib is a disease that is related to inflammation. And so the way I'm going to do that is first I'm going to show you some medical illnesses that have a lot of inflammation that comes with it. And then I'm going to show you that those illnesses are actually associated with an increased risk of atrial fibrillation. That's the first component. The second component is I'm going to show you some evidence that inflammatory proteins that we sometimes commonly use in our clinical practice, sometimes we don't. Those inflammatory proteins are actually elevated in patients with atrial fibrillation compared to patients who don't have atrial fibrillation. That will be the second component. And the third component will be some animal studies. I didn't want to go over a lot of them with you because you may not be familiar with a lot of stuff that we do in the animal labs, but I just wanted to show you at least a quick piece of what is done in the animal labs, because all that we do in the clinical practice is irrelevant because we can only prove an association. We can't actually prove a causality to inflammation and AFib, so we have to show some evidence that it really does cause AFib inflammation. So I actually am going to show you some animal studies. And then the last part, I'm going to show you how there is still a lot of contradiction and controversy about anti-inflammatory drugs as a treatment for atrial fibrillation. That is right now not clearly understood how it's going to help. So here is a conduction system of the heart. So the normal heartbeat comes off from the pacemaker. I call it the pacemaker that you're born with, not the ones that you can buy in the market. That's called the SA node. So that electrical impulse actually, flows to the atrium, the two atria, and the atria contract blood from the top to the bottom chamber. And there is a delay in that electrical impulse in the AV node, and then it goes down to the His bundle, and the His bundle separates out into right bundle and left bundle, and then that's how the electrical impulse is carried to the rest of the ventricle. So that is the normal conduction system of the heart. And so when your heart beats normally, the heartbeat comes off from the top chamber, goes through the AV node, goes into the ventricle, your ventricle beats regularly, and as you can see, the EKG has a nice P wave and QRS complexes. So that's how you have a normal heart rhythm. Now when you have AFib, your heart doesn't contract or beat regularly. It has a very chaotic and irregular heart rhythm, and the reason for that is the electrical impulses come from different parts of the heart. Most often, these triggers are actually coming from the pulmonary veins, which are located on the left side of the heart, on the left atrium. So these pulmonary veins have cells in the muscle sleeves that have these chaotic heart rhythm that beat about 300, 400 times a minute, and that electrical impulse is actually generated into the atrium or spreads into the atrium and makes the atrium contract at 300 times a minute, and that's what causes AFib. And it's very chaotic because the conduction system in the atria is completely screwed up, and so it just goes everywhere and beats chaotically. So that's AFib. So what does AFib do to the US healthcare system? So right now, about in 2015, in the US, we have about 8 million patients with AFib. And by the year 2050, we will have about 16 million patients with atrial fibrillation. This is not even taking into account any factors that increase the incidence of AFib. This is just based totally on the fact that we will have more older patients or older population in the US by the year 2050, and then we will have more obese patients or obese population by the year 2050. Just taking those two into account, we will have about 16 million patients with AFib. Now, if there are something that comes along the way that, some dietary things that changes in the US population that increases the incidence of AFib from what it is currently, you will see even more of AFib. So it costs a lot of money to the US healthcare system. So if you are a man or a woman above the age of 40, you have a 1 in 4 lifetime risk of having atrial fibrillation, which is pretty significant, I think. 1 in 4 over the age of 40 will have AFib by the time they die. And so why is AFib so important? We talk about rate control, rhythm control, we talk about symptoms, and we say, if you don't have symptoms, we just leave you in AFib. What is the problem with leaving somebody in AFib? It's not corrected by putting them back into sinus rhythm, don't get me wrong, but what is the impact of AFib? So AFib causes a ton of stroke. The reason it causes a lot more stroke than, say, peripheral arterial embolization, for example, is this diagram here. So, and what do you think is the average size of cardiac emboli that arises from the left atrium when you have somebody in AFib? 1 millimeter? 2? So the average size, not the biggest one, the average size of a cardiac emboli is about 3.5 millimeters in diameter. Okay, so that's pretty big actually. So if you look at the left anterior descending artery, which is one of the main arteries that supply blood to your heart, the left anterior descending artery has a diameter of about 4 millimeter roughly. Okay, and if you look at the femoral artery, which you palpate for pulse, or you put a central venous catheter in to do a cardiac not venous catheter, but arterial catheter, that is about a centimeter. So it's about 10 millimeters to 11 millimeters in size, an average femoral artery. So in comparison to that, the middle cardiac artery and the anterior cardiac artery and the posterior cardiac artery are about roughly between 1.5 millimeters and 2 millimeters. Okay, so they are barely, a millimeter or 2. And so if you have a cardiac emboli that is about 3.5 millimeters, the first place it's going to occlude is the brain before it occludes any other arterial system in your body. And that's why you have more strokes in AFib than you have peripheral arterial occlusions and ischemia. So we do see a lot more strokes in patients with AFib, and as you can see here, approximately 8 ischemic strokes in an hour in the United States. So about 795,000 strokes annually, out of which about 87% of them are ischemic strokes, the rest of them are hemorrhagic strokes. 20% of all the ischemic strokes are cardiac emboli, about 138,000. And of them, about 50% comes from AFib. So AFib approximately causes 8 ischemic strokes per hour in this country. So we have a lot more strokes. Not only that, when you have a patient with stroke from AFib, and then you have a patient with stroke with a non-AFib cause, say for example a carotid arterial atherosclerosis, or you say you had a fat block that went from the aorta to cause a stroke, that's also embolic stroke. But those strokes are less detrimental to the patient and cause less morbidity and disability compared to the strokes that are caused by AFib, purely because of the size of the emboli that takes off from the atria when you are in atrial fibrillation compared to the size of emboli from any other source. So if you look at the acute phase, about 73% of patients who have a stroke due to AFib have severe disability compared to 33% who have a stroke from other causes. But the more important point is, even in the long term, at 12 months out of the stroke, you still have about a 30% patient population who had a stroke from AFib still having severe disability, compared to only about 11% of patients who have a stroke from other causes. This is actually data from the Framingham Heart Study, which about 5,000 patients in that group, and about 501 strokes were totally found in that patient population. 1/5 of them were from AFib, and this is what they found is that the disability from a stroke that's caused by AFib is far more detrimental and disabling than a stroke that is caused by any other causes of stroke. This is another piece of data from Framingham Heart Study, and this is also about 5,000 patients. And not only AFib causes increased strokes, but also causes increased mortality. So if you look at this, these are female patients who don't have AFib, and this line here is female patients who have AFib. So if you look at it, there are more mortality in female patients who have AFib compared to the female patients who don't have AFib. Same thing with males. Males who don't have AFib, the mortality is here, and the mortality curve for males with AFib is up here. So there is a significant difference in mortality in patients with AFib and without AFib. I'm not saying that AFib is causing the increased mortality, but there is an associated increase in mortality in patients with AFib when compared to patients without AFib. So it is something that we need to pay attention to and do all that we can to actually decrease that mortality. So here are the common risk factors for atrial fibrillation. So what is the most common risk factor for AFib? What's that? High blood pressure. So that is the most reversible cause of risk factor for AFib is hypertension, but the most common cause is age. Actually, just increasing age actually predisposes you to have more AFib than if you were younger. But hypertension, as Desiree was saying, is the most common reversible cause of AFib. If you look at all of these factors here, there is something common to most of them. Not all of them, but most of them. What it is that we don't think about hypertension and inflammation all the time, but there is a lot of research that goes into inflammation as a cause for hypertension. Actually, our center here, there's a lot of vascular biologists on the basic science side who work on this, specifically looking at how does inflammation cause hypertension. And so hypertension has inflammation associated with it. CHF, it's well documented now. There is a lot of inflammation in heart failure patients. Obesity clearly has inflammation associated with it. Age has some inflammation associated with it. Diabetes. So if you think about most of these things, they all have inflammation as a common factor that is associated with them. And so they all cause AFib. So there is some kind of a thought process that goes into this, thinking like, okay, if all these things all this inflammation causes these different risk factors that causes AFib, maybe inflammation causes AFib directly as well. So that's how we come up with this hypothesis that inflammation may be a cause of AFib. So here is a slide that's pretty intimidating, but it's pretty simple. This is a common pathophysiology slide, very well known in the EP circles, that explains all the different triggering factors for AFib. And I'm showing you this for a specific reason. So here are the triggers for AFib. So when you think about AFib, there are two things that causes AFib. One is a trigger, which means that there is some cell somewhere that beats out of sync that triggers the AFib. And then there is something called substrate for AFib, which is basically the fibrosis and the fibrosis in the atrium that sustains the AFib. So trigger and substrate, okay? So if you think about the triggers most often come from the pulmonary veins. So the pulmonary vein foci is the most important trigger for AFib, and that's why we do pulmonary vein isolation when we do AFib ablations. The only thing we do is to isolate these pulmonary veins electrically from the rest of the left atrium, so the pulmonary vein foci that does not enter into the atrium. But there are other less known triggers for AFib. There are micro-reentrant circuits in the heart. There are triggers which are located in the ligament of Marshall, which is a remnant of the vein of Marshall. There are triggers that are caused by the vagal ganglia, and then there are dominant spiral waves. These are now actually one of the targets for ablation. We call them rotors. So now we ablate all these things. So these are the triggers for AFib. Can these triggers be caused by inflammation? Yes. How does inflammation cause these triggers? Inflammation causes calcium imbalance in cells. Something you don't think about on a normal day-to-day basis, but in the basic science lab, we do know that inflammation causes calcium overload and calcium imbalance in the cells. When you have calcium imbalance in the cells, it can actually prolong action potentials and cause what is called EADs and DADs, which are early after depolarization or delayed after depolarization. Both of them are known to cause triggers in cells that causes AFib. And also, most importantly, inflammation causes the substrate modification that I was telling you about. It causes ultrastructural changes in the atria. It causes matrix remodeling, and also it causes a lot of fibrosis in the atria that then sustains the atrial fibrillation once the trigger is being produced. So inflammation can affect both components of atrial fibrillation. It can affect the trigger and cause the trigger, but it can also affect the substrate to sustain the atrial fibrillation once the trigger comes on. All right, so the first part of this, I told you, I'm going to show you some evidence of association of inflammatory conditions and how AFib is actually increased in these conditions. The first one that I'm going to show you is this study with about 60,000 odd patients. All of them are Medicare beneficiaries. They are all admitted to the hospital for sepsis, okay? So these patients were all admitted to the hospital for sepsis. And if you look at the incidence of atrial fibrillation totally, it's about 24 to 25% of them, roughly 25% of them will have AFib during that hospitalization for sepsis, okay? So how did I come up with sepsis? When I actually initially wanted to do some studies in my lab looking at some specific proteins that are linked to inflammation and wanted to infuse these proteins and look at AFib incidence, one of the basic scientists here said, told me like, why are you looking at one specific protein? Why can't you choose a model that has this big inflammatory component to it? And the biggest inflammatory component in any disease is sepsis, right? So sepsis has the biggest inflammation in it. So that's how I started to look at this. And then if you look at it, sepsis is very uniquely and consistently associated with atrial fibrillation. And you would have seen this in your clinical practice when you're in the ICU taking care of sepsis patients. Often they have coexistent atrial fibrillation. So about 25% of these 60,000 patients will have AFib during the hospitalization for sepsis. But then about 18% of them will have a pre-existent history of AFib. So if you just look at the new onset AFib just in that admission in patients with sepsis, about 7 to 8% of them will have new onset atrial fibrillation during that admission for sepsis. And if you look at it more closely, patients who are in the intensive care unit with sepsis have a higher risk of new onset atrial fibrillation compared to patients who are not in the intensive care unit. So about 10% of patients in the ICU with sepsis will have a new onset atrial fibrillation during that admission. So that tells you that there is some kind of a link between sepsis, inflammation, and atrial fibrillation. Here is a meta-analysis of studies that were specifically looking at the same question. There are about 11 studies in this meta-analysis, and this study has actually separated sepsis out into like sepsis or mild sepsis, severe sepsis, and septic shock. So the weighted mean incidence of atrial fibrillation for mild sepsis was about 8%, for severe sepsis was about 10%, and in septic shock there was almost a 25% incidence of atrial fibrillation in these patients admitted with septic shock. So that again clearly tells me that there is some kind of a linkage between sepsis, inflammation, and AFib. The other major disease process that we see AFib a lot is actually post-operative phase, whether it's a cardiac surgery or a non-cardiac surgery. Most of these patients in the post-operative period will have some atrial fibrillation. So if you look at the time course of post-op patients, so the post-op day 0, and the dotted green line here is cardiothoracic surgery patients, post-CABG patients, or post-valvular surgery patients. And the dotted blue line here is actually non-cardiac surgery patients. And the thick red line here shows the CRP levels during that time. So if you look at it, patients who undergo a non-cardiac surgery have the peak incidence of sepsis between 1 and 2 days post-operatively. Patients who undergo a cardiac surgery have a peak incidence of atrial fibrillation between 2 and 3 days, right here. And if you look at the CRP levels, which is basically for the medical students, this is a protein, an inflammatory protein that is secreted by the liver in response to IL-6, another cytokine, is something that we actually check often in medical practice for inflammation. So that inflammatory protein, which is CRP, peaks right at the same time where you see increased incidence of AFib in these post-op patients who have cardiothoracic surgery done, or in fact, even in patients who have non-cardiothoracic surgery done. So again, another factor that plays into this hypothesis that shows that AFib may be related to inflammation. Now, why do patients with post-operative period have AFib? So, during surgery they could have a lot of pain or hypothermia or hypoglycemia that could cause increased sympathetic outflow, and we do know that sympathetic outflow increases incidence of AFib. They could also have anemia or hypoxia or altered volume status, hypervolemia or hypovolemia, that can also cause post-operative AFib. But most importantly, what I wanted to show you here was thoracic surgery leads to local inflammation in the thoracic cavity around the heart, and non-thoracic surgery leads to systemic inflammation. And I think that both of these actually play a major role in causing post-operative atrial fibrillation. Why am I thinking this? So if you think about it, if all these things, pain or hypervolemia or hypothermia or hypokalemia, was the only cause of AFib, then everybody should have AFib. So why are some patients having AFib and some patients don't? That's because of this. So if you look at it, this line here is the AFib threshold. So this is basically the substrate that causes AFib, both triggers as well as the substrate modification that causes AFib. So that is the trigger for AFib. Now, if you have two patients, one of them has only hypertension, they basically have some substrate for AFib due to their hypertension, and then they have the surgery done at day 0. Their substrate, because of inflammation, pain, and all those things, go up a little bit, but they don't cross the AFib threshold to have a clinical AFib. Okay? But when you take this patient 2 that has a lot more factors that adds into the substrate for AFib, they have hypertension, diabetes, mitral regurgitation, COPD, all these things causes both inflammation and substrate modification. And then on top of that, you have a surgery done at day 0. This patient now crosses that threshold for AFib and will have a clinical AFib in your practice. So that is why I think post-operative AFib patients, not every single patient who is in the post-operative period will get AFib, but some of them will. All right, so next I'm going to show you some evidence that talks about what are the inflammatory markers doing in patients with AFib compared to patients who do not have AFib. And when we talk about inflammation, mostly we're talking about inflammatory cell infiltrates into the tissue or into the vascular space, and that actually causes increased oxidative stress or reactive oxygen species, or these cells actually release cytokines. These two together then actually produce tissue degrading or reparative enzymes that it modifies the matrix of the atria, and then that causes inflammation in the atria and atrial remodeling and AFib. So the first part that I told you here was these inflammatory cells. So what is the evidence that we do have inflammatory cells in patients with AFib? Here is a study that was done back in 1997, published in Circulation. They took about 12 patients with AFib, compared those atrial samples to patients who had just WPW syndrome. They both had endocardial biopsy done, and they looked at the cell infiltrates within the atria. As you can see here, the patients with AFib had a lot more lymphocytes and macrophages in their atria and had some myocardial necrosis in those areas compared to patients who had just WPW. So those patients did not have a lot more lymphocytes and macrophages. So that actually tells you that there is more polymorphonuclear neutrophils and macrophages in the substrate for AFib. So here is a very simple study. This is actually a big study that was done primarily to look at the risk factors for atherosclerosis. It's called ARIC. It's a big study that was multi-center, has about 15,000 patients in it. It's one of the biggest of its kind. What they did was they basically took a bunch of patients that didn't have any comorbidities, any problems whatsoever. They measured their baseline, chemistry like WBC count and CBCD, CMP, all the basic things. They took some tissue for gene testing. They also took some history and EKG and all those things. And then they followed these patients over a period of about 22 years, I think. It's 22 years actually. So they followed these patients for 22 years and figured out which patients had CAD or atherosclerosis or had AFib and the ones that didn't have AFib. And so if you take their baseline WBC count, okay, so these histograms here, the bars here represent the the patients with a WBC count. So here is the WBC count between 3,000 and 12,000. And these are the number of patients that had that WBC count within that 15,000 patient population, right? And then they saw which patients went into AFib. So if you look at it, this is the hazard ratio curve for the hazard of having AFib during the course of these 22 years. So if you had more WBC count, you had more hazard of having AFib. So your risk of having AFib went up about 1.09. So the hazard ratio was 1.09, the more WBC count you had. And then if you split the WBC count into differential, and this is neutrophil count, this is monocyte count, this is neutrophil to lymphocyte ratio. If you look at it, with each of these, neutrophil count goes up, AFib goes up. If your baseline monocyte count goes up, your AFib risk goes up. And one of the things that negatively correlated with AFib, which I haven't shown you in this graph here, is lymphocytes. If you had more lymphocytes, your risk of AFib actually went down. So if you look at the neutrophil to lymphocyte ratio, so you put lymphocyte at the bottom of the fraction, and you put the number of neutrophils at the top, on the top portion of the fraction, if that number was higher, you had a higher risk of AFib. And that was shown in this elegant study. That's a very simple study that was done to show this. But if you look at the actual neutrophil lymphocyte ratio, there are lots of studies that have been done regarding that. And here is a meta-analysis divided into two groups here. This is all surgeries, this is cardiac surgeries, post-cardioversion and post-AFib ablation patients. And in both these, what it shows is that if you had a higher neutrophil to lymphocyte ratio, you had a higher hazard ratio of having AFib. So if your neutrophil to lymphocyte ratio was higher, you had more risk of developing AFib. So here is another evidence that inflammation plays into AFib. So this is, what they did was they took patients, about 30 patients with AFib and 30 patients who didn't have AFib. And you know, where is all the inflammatory cells coming from mostly? Where is the biggest producer of hematopoietic tissue? Yeah, spleen, right? So you have a lot of hematopoietic tissue in the spleen. So they actually looked at the splenic metabolic activity with a PET scan. So they looked at the PET scan and looked at how much metabolic activity they were having in the spleen versus aorta. And in both these locations, if you had AFib, which is the blue bar here, you have a higher metabolic activity in the spleen and the aorta compared to patients who did not have AFib. Again, showing that there is a higher inflammatory rate in patients who have AFib compared to patients who did not have AFib. So here is a whole bunch of other proteins that people have looked at. I just want to show you a few things. I don't have time to go over all these things, and we'll go over some of these things today. CRP, as I told you, is the one that has been looked at the most. I think there are thousands of studies looking at CRP in relationship to AFib. The results have so far been very confusing. So the biggest disappointment of all of these proteins is CRP. Because CRP probably is has a lot of non-specificity to it, so it may be actually increased in other conditions as well. So CRP hasn't panned out as an indicator for which patients will develop AFib. So that is the disappointment there. But if you look at the ones that have actually panned out, that is HSP27, that has been shown both to correlate with AFib patients in serum levels as well as atrial tissue levels. Also been shown to actually induce AFib in animal models, and has actually been shown to cause AFib recurrence in patients who've had AFib ablation done. The other one is TGF-beta. Also, it has been correlated to patients with AFib in atrial tissue, has been shown to induce AFib in animal models. So we're going to talk about some of these things. But these are all the things that have been looked at different levels. So this one, they've looked at serum or atrial levels to look at whether patients with AFib do have increased protein levels of these markers that we are talking about compared to patients who don't have AFib. These four here, predictor of AFib, this is general occurrence of AFib, this is after surgery, after cardioversion, after ablation. What they do here is they measure the baseline levels of these protein markers, and then they follow these patients to see which of them will recur into AFib after a cardioversion, after a cardiac surgery, or after AFib ablation. So this, I've just put this out here, but the most important things I told you about are CRP, TGF-beta, and also IL-6 actually has a little bit of data behind it. So let me show you some of them. All right, so here is the CRP data. This is about 3,000 odd patients in Framingham study again. And they separated these patients with the patients that had the highest tertile of CRP levels, the middle tertile, and the lowest tertile of CRP levels. And if you look at the incidence of AFib, the highest AFib rate was actually in the patients who had the highest tertile of CRP levels. Again, showing that if you have a baseline inflammatory rate that is much higher than your colleague or your counterpart, you're going to have a higher incidence of atrial fibrillation in your lifetime compared to patients who don't have inflammation. So as I told you before, CRP has been looked at a lot, and these are all the studies that have looked at CRP. I just put it in there to show you, really, I wasn't joking. There are a lot of studies that actually have looked at CRP levels. And so basically what this shows is CRP positively correlates with patients with permanent AFib and persistent AFib, but does not correlate with patients who have paroxysmal AFib. So they could not show that patients with paroxysmal AFib had a higher CRP levels compared to patients who did not have AFib. But when they compared it to patients with permanent and persistent AFib, those patients did have a higher CRP levels compared to their colleagues who did not have AFib. And IL-6 and ICAM-1 is intercellular adhesion molecule 1. For the basic, the medical students here, they probably know what this is. The clinicians may have forgotten what this is. This is basically a surface glycoprotein that is in the endothelial cells that actually help an activated polymorphonuclear neutrophil attach to it with its integrins and then move out of the cell to cause the tissue inflammation, basically. So people have looked at both IL-6 and ICAM levels in patients, human patients with AFib. So in this study, what they did was there were about 300 patients. They measured the IL-6 and ICAM levels, and then they shot the patients back into normal rhythm. And then they went on to follow these patients to see which patients recurred back into AFib and which patients did not. And they compared these levels with controls who didn't have AFib at all. So as you can see here, patients with paroxysmal AFib have a higher IL-6 level compared to controls, and much higher in patients who have recurrent AFib. So if you have a higher IL-6 level, you actually had a higher rate of recurrence after they cardioverted you back to sinus rhythm. So this could be used as a marker in the future of which patients you're going to cardiovert and put them back into sinus rhythm, and which patients you cannot because they're going to anyway recur back into AFib. This could be in the future could be used as a marker. Again, the same thing with ICAM-1. ICAM-1, the paroxysmal AFib patients were not very different from the controls, but the patients who recurred into AFib still had a higher ICAM-1 level compared to controls and patients who had paroxysmal AFib. So this is again a meta-analysis showing all the studies that have looked at IL-6 as a marker in AFib, and it all shows that if you had a higher IL-6 level, you had a higher incidence of AFib. And same thing with TNF-Alpha, which is another protein marker that depicts inflammation in patients. So moving over from that to some basic science studies that I told you about that I was going to show you. Stay with me for this portion. It's pretty interesting, and it shows you that if you actually alter a protein, you alter a gene that causes inflammation, then you follow these mice or rats or pigs or whatever they are, you will see higher rates of AFib in those animal models. That is a pretty compelling evidence compared to all that I showed you before, because it could be a coexistent factor. Some of the comorbidities could be doing these things. We don't know for sure, but this is a more clear model that shows, or clear evidence that shows that inflammation causes AFib. So the first one is actually this model here. Most of these are actually mice. In this mice model, what they did was they caused a transaortic constriction. So it's basically a model of heart failure. When they did that model of heart failure and they looked at the tissue, there were a lot of mast cells in the substrate of the atrium. See, all these blue cells that you see here are mast cells. So if this is sham operation, means they did not actually tie the aorta. So basically, it's a control animal. This is the mouse that has the heart failure, and this is the mouse that was actually operated on, caused them to have heart failure, but they put them on a mast cell stabilizer, which is chromolan sodium. And then, so if you look at it, the mast cells are actually decreased again in this model because they use the mast cell stabilizer. So if you look at the AFib incidence in these mouse, if you look at the sham versus the ones that had this transaortic constriction done, the mouse that had the transaortic constrictions had more episodes of AFib and also had longer durations of AFib compared to the sham animals. But when you actually use the chromolan sodium to take away the inflammation, you actually came back with almost control levels of AFib, both in duration as well as the number of episodes of AFib. So if you control inflammation in this model, you actually could revert it back to a normal level. This is a model where they knocked out the integrins. You know, integrins, as I told you before, are these surface markers on activated polymorphonuclear neutrophils that actually helps them to attach to the endothelial cells and go out of the endothelial cells to cause tissue inflammation. So they knock that molecule out. So that is CD11B. So when you see CD11B minus, basically that's a knockout mice that does not have that protein. So basically they're not capable of mounting an inflammation. So they took normal animals and they took these knockout animals, and they either gave them saline or they gave them angiotensin II for a period of about 21 days. Angiotensin II is known to cause inflammation, known to cause hypertension, and known to cause atrial fibrillation in these models. And I actually use a similar model like this where we infuse angiotensin II. It causes AFib in the mice. So this is the number of polymorphonuclear cells in the atria. So if you look at it, the wild type mice that were infused angiotensin II had a higher levels of polymorphonuclear neutrophils in the atria. But when you looked at the CD11B knockout mice, they did not have a lot of polymorphonuclear neutrophils. Basically, the infiltrative cells in the atria were lower. And if you looked at the atrial conduction velocity, so from red to blue is the duration of time it takes for the conduction to go from one end of the tissue to the other. These are all atrial tissue. So in wild type mice, it takes about 20 to 50 milliseconds. In Ang2 infused mice, that conduction velocity is decreased because the inflammation and hypertension causes more fibrosis in the atria. So that conduction velocity goes down. So it takes about 4,050 microseconds to actually go across this piece of tissue. But when you look at the CD11B knockout mice, whether you gave saline or Ang2, that conduction velocity did not change. It was very similar to the wild type mice that were given saline. So that shows you that the conduction velocity fibrosis does not increase in these CD11B knockout mice. Also shows you the number of polymorphonuclear cells in the atria is the same. And here is the crucial piece of data. So what this is basically we have a similar setup in my lab. We put a catheter through the right intrajugular vein into the right atria of the mice, and then we can record from that and trigger pace from that. So if you pace mice at a really fast heart rate, do you guys know what the normal heart rate of mice are? 150? So yeah, it's about 300 to 600 actually. An active mice will have a heart rate of about 700 beats per minute. So if you trigger pace in the atria about 800 to 1000 beats a minute, you can induce AFib in mice. So here on the left is the trigger pacing. So we're just pacing really fast in the atria, and then we let go of the pacing and see what happens to the rhythm. And same thing is done here, same thing is done here. And so this mice that was given Ang2, but it's a wild type mice, went into AFib. The evidence for that is these big spikes are ventricular complexes or QRSs, and these small spikes here are the fibrillatory waves that are recorded from the atria. So you see this mice actually remained in AFib after the pacing was stopped. But on this one, this mice actually went into AFib for a short period of time, as you can see here, very tiny, and then went back into sinus rhythm here. So you can see a atrial contraction and a ventricular contraction, atrial contraction, ventricular contraction. So this mice went into AFib, this one did not. This is the one that has the CD11B knocked out, so it cannot mount an inflammatory response. So even with angiotensin II, those mice do not go into AFib compared to the wild type ones. This is a similar experiment done in the myeloperoxidase knockout mice. Now myeloperoxidase is an enzyme that is very important in inflammation, as you guys would know, hopefully. And they took patients with AFib and they compared them to controls who didn't have AFib. They looked at their myeloperoxidase levels. As you can see here, patients with AFib had a higher MPO levels compared to patients who did not have AFib. That is step one. So they went from human beings, they took their samples, they measured the MPO levels, they showed that patients with AFib had a higher MPO levels. Then they took a mice model or mouse model that had MPO knocked out, and they did the same thing like we talked about before. They gave Ang2 to some mice that had wild type, and then they gave Ang2 to these mice that had MPO knocked out. As you can see, the mouse that had MPO knocked out, even with Ang2, did not have increased AFib inducibility compared to the wild type animals that were infused with angiotensin II. Again, shows that MPO is an integral component, and this figure shows that there is increased fibrosis in the atria of the wild type mice treated with angiotensin II, which is here. The red signaling here is actually from picoserous red, which is actually staining the fibroblasts. Whereas here, the MPO knockout mice, the angiotensin II, did not cause an increase in fibrosis. Last one here is the TNF-alpha and AFib. How many of you know that AFib, there is an increased incidence of AFib in endurance athletes, marathon runners? One. Okay, so most of you don't know. So there is a lot of data now out there that clearly shows that if you're a marathon runner or long distance runner, you run more than 20 miles a week, you have an increased incidence of AFib compared to people who don't run. So this model is actually a mouse model that replicates that. It's very, very elegantly done. They took mice and they put them on a treadmill, or they let them swim, and some mice they just didn't let them do any physical activity. They just kept them in the cages. And they did this trigger pacing that we talked about before. See, the sedentary mice is in sinus rhythm after they stop pacing in the atria. The mouse that was swimming, I think it was 6 hours a day or something like that. They had actually a specific number of hours they let these mice actually swim or walk on the treadmill. Those mice had increased AFib. The mouse that was walking on the treadmill forever was also having increased AFib. Clearly replicates that endurance athletes actually have AFib. But the key here is that these patients also had increased, these mice actually had also increased fibrosis. Again, this is picoserous staining with the immunofluorescent staining that shows that the swimming exercise mice actually have increased fibrosis. They have decreased conduction velocity, and they have increased AFib compared to the sedentary mice. And then if you knock out TNF-alpha, which is again a big inflammatory protein in our system, those mice that were actually swimming or walking on the treadmill were rescued from that phenotype, which means that these mice did not develop AFib anymore. So the mice that were swimming and having AFib, if you reverse that inflammation by knocking off TNF-alpha, or you give etanercept, which is a drug that you know will compete with TNF-alpha, then you actually have decreased incidence of AFib in these mice. So with that, I'm going to move over to the last part of this talk, which is actually the evidence with regards to treatment. Unfortunately, all these things that I talked about with regards to inflammation and AFib didn't pan out as much into a treatment modality that we can use currently in clinical practice. But there is some evidence that shows that targeting inflammation might work in patients with AFib. Here is one piece of evidence. These are about 300 patients that went on to have cardiothoracic surgery. They're all CABG patients. They divided these patients, randomized these patients to steroids or no steroids. They gave them hydrocortisone shots before the surgery and 1 day after the surgery. And they followed these patients till they got discharged and saw if these patients went into AFib or not. So these are the hydrocortisone patients, and the dotted lines are the patients who did not get hydrocortisone after the surgery. And this is basically shows you how many patients remained in sinus rhythm. So if you look at it, less number of patients who did not get hydrocortisone shots remained in sinus rhythm after the surgery until discharge compared to patients who got hydrocortisone shots. So if you give steroids, you can prevent post-operative atrial fibrillation in some patients. So this is one piece of evidence. Colchicine is another drug, anti-inflammatory drug that we often use in clinical practice, mostly in rheumatology, but nowadays we do a lot in cardiology as well for pericarditis and AFib. And that was actually tested in a similar manner. Post-op patients, they randomized these patients to colchicine and no colchicine. So although they were able to reduce the number of post-pericardiotomy syndrome patients, these are patients who have chest pain and pleuritic chest pain after the surgery, they were able to reduce that incidence of post-pericarditis, but they were not able to reduce the incidence of AFib in these patients. So colchicine did not pan out in this study, which was actually published in JAMA. One of the big studies that was done in colchicine did not pan out into a good option for treating patients. These are about 300 patients again that were randomized to colchicine and controls. post-AFib ablation. So these are patients all had AFib. They got them in, they did an AFib ablation, they randomized them into colchicine or no colchicine, and they followed these patients to see how many of them stayed in sinus rhythm. So if you look at it, the patients who got colchicine stayed more in sinus rhythm compared to controls. Okay, so in these patients, it does work, and that's why some of my fellows may not have seen this data. I use colchicine for every patient that I do a AFib ablation on for 7 days after their post-AFib ablation. So this comes from this data. That shows clearly that colchicine will prevent recurrence of AFib after you do an AFib ablation. The last piece of evidence is this. This is contradictory to all that we talked about. This is actually called a Rotterdam study that has about 7,000 odd patients. They looked at all the patients who developed AFib. So those were cases, and the rest of them were controls. 300 odd patients who had AFib. Out of the 7,000 were cases. The rest of them were controls. And they went back and saw how many of these patients were started on high dose or low dose steroids within 30 days from the onset of AFib. So if you look at it, patients who had high dose steroids started within 30 days from the onset of AFib had a higher risk of AFib. Opposite to what we talked about is if you actually got steroids, a high dose steroid, within 30 days you actually have a higher incidence of AFib within the next 30 days compared to patients who did not get steroids, and even compared to patients who got low dose steroids. So that's where we are with therapy for anti-inflammatory therapy for AFib. So we don't know exactly how we're going to deal with it yet. So in summary, AFib is the most common arrhythmia that carries a high risk of morbidity and mortality. Like I showed you before, it carries increased risk of stroke as well as mortality. It is triggered by conditions that are associated with systemic inflammation and local inflammation in the thoracic cavity. And inflammatory markers are increased in patients with AFib, but we don't know if it's an association or causality. But the animal models do show that there is some causal relationship between AFib and inflammation. And finally, therapy for AFib with regards to anti-inflammatory therapy, we're still not clear where it stands right now. So with that, I'll take any questions.
Thank you, Dr. Dominic. That was an interesting talk about atrial fibrillation and inflammation. You talked about the splenic metabolic activity. A few days back, I was actually reading about stroke, and after the initial insult in stroke, there is a similar increase in splenic metabolic activity, and what I studied in that paper, there is a massive release of splenic monocytes, which is associated, eventually causes associated comorbidities and increase in the stroke risk. Has there been, as you mentioned in the beginning, in the non-thoracic and thoracic surgical patients, then there is an increase in the splenic metabolic activity. Is there a similar mechanism, how the spleen senses this, and eventually there's a release of, like I said, splenic monocytes, which then eventually lead to atrial fibrillation? Is there something like that?
I think this is, so we are actually looking at genetic causes of increased inflammatory activity as a cause for AFib. So I'm thinking there is some kind of insult that leads to inflammation in these patients that actually causes. What it is, I don't know for sure, and how it's sensed by the hematopoietic system and why the hematopoietic system releases all these inflammatory cells, I'm not really sure. I really think that there is more of a local inflammation. For example, if you have hypertension, you have local inflammation in the endothelium that causes inflammatory cells to leak out into the atrial tissue that causes AFib. That's an interesting, observation that stroke patients actually have increased metabolic activity in the spleen. I'm wondering if that is baseline, or because now we do know that a lot of cryptogenic strokes are caused by AFib. And so is it because these patients have increased AFib that they have increased, metabolic activity in the spleen? I don't know for sure how that study was done, but it's an interesting observation.
Other question, you did mention about neutrophils, a release of all these inflammatory but is there also any role of platelets and complement activation after the initial insult?
Oh, definitely yes. There is actually some data on PDGF. I showed you that tabular column, and the PDGF actually definitely plays a role in inflammation and AFib as well. So there is some data on that. I can't pull up that exact study, but there is some data on that.
Thank you.
And do you have any information regarding ultrastructural changes or metabolic changes in mitochondria in patients with chronic atrial fib?
Oh yes, definitely there is a lot of ultrastructural changes in the mitochondria. Mostly to do with the reactive oxygen species, components in it, and also there is a lot of calcium signaling changes in the mitochondria. The models that have actually seen ultrastructural changes in the mitochondria, they also have AFib. They also have heart failure. So I don't know for sure the ultrastructural changes were actually related to heart failure or AFib. These models have AFib and heart failure, so I can't tell you for sure. I don't think people have looked at human samples for ultrastructural changes in the mitochondria.
We looked at humans with heart failure back in the 80s with triplicate myocardial biopsies we're able to measure mitochondrial function through the Krebs cycle. And as interesting as their left ventricular stroke work index increased, their Krebs cycle activity decreased. They got uncoupling of oxidative phosphorylation.
Okay.
And they also, ultrastructurally, their mitochondria, instead of looking oblong, began to look like little basketballs.
Wow, okay.
And the Christi were dramatically disturbed.
Okay.
So I was wondering if this has...
So my mentor is actually working on a specific enzyme within the mitochondria called calcium calmodulin kinase 2, and he actually sees ultrastructural changes in the mitochondria. That mice also has AFib and heart failure as well. They do actually see changes in the seahorse studies that they look at oxygen consumption and all those things. But yeah, I don't know exactly if it is from heart failure or from AFib.
Right.
Sir.
In patients who have obstructive sleep apnea, there is a high incidence of atrial fibrillation, and if the patients use more than 4 hours in some studies, there is a declination of the uric acid, of the inflammatory markers, if they use CPAP more than 4 hours. What is your approach with the sleep apnea and atrial fibrillation?
That's a very good question. Actually, I don't know if you've seen similar studies looked at patients with AFib as well. Using 4 hours of CPAP a day actually decreases the incidence of AFib as well. So that actually very well correlates. I do not know about the inflammatory studies, but I do know about the AFib recurrence studies. And so what I do in my practice is if patients come in with AFib and they have hypoxia, they have sleep apnea, and they don't use CPAP, I tell them that there is no reason to actually cardiovert them into sinus rhythm because they will not stay in sinus rhythm with CPAP, with sleep apnea untreated. So what I do is I usually, kind of convince them that they need to go on CPAP for at least a month before I can either do a cardioversion or put them on an antiarrhythmic agent or do an ablation procedure on them. That's my general approach. There have been patients that haven't taken up my advice, and I just updated a guy last Thursday that had AFib and had sleep apnea. He's a respiratory therapist who doesn't want to use CPAP, so I can't force him. So occasionally we do have patients like that, but in general I like to treat their sleep apnea first before I do anything with their AFib. And I even tell them that it will go away. They may not even need AFib ablation or cardioversion.
Is there a mechanistic role of pericardial fat pad, data on that, and how does it play with the inflammation and?
Yeah, the data on pericardial fat pad is clear that increased pericardial fat pad actually increases AFib, but the inflammation data on that I think is tricky. There is some data, but it is kind of non-specific. It's not looking specifically at certain inflammatory markers. They've looked at some changes in the glycogen storage and glucose and all those things. So it's kind of indirect data. I'm not sure how pericardial fat pad plays into inflammation that causes it. All right, no more questions. Thank you.